Thank you. And thank you everyone for being here. It is so nice to see so many of you week after week. One of the things that we love about Echo that we do here is we build a community. And so I just wanted to thank all of you for coming and welcome everyone. And if you're new, you're very welcome to be here as well. We just appreciate you giving us a little bit of your time. I'm going to do the same. Now Drake's put the pressure on for me to freshen things up, but mine, it's pretty standard. What we call ourselves is Minnesota Project Scope. It stands for Supporting Children of the Opioid Epidemic. We're one of the few projects focusing on early intervention providers. The feedback we've had in the States is that early intervention providers are seeing families that are influenced by the opioid epidemic, but aren't getting a lot of training or information about it. So our goal is to bring some of this training and knowledge about opioids and families and children and neonatal abstinence syndrome to you, and then also to hear what you're experiencing out in the field. Let's see. And so I've covered some of that. We're going to focus on what we call neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. That's a mouthful. We're a community of early intervention providers supporting children and families, and we use the Echo virtual training model. Next slide. And all of you know this probably who've been on before, but Echo, you hear it a lot in healthcare. Dr. Prekker, I'm sure you've been a part of other Echoes, or I'm being presumptuous, but I'm assuming you've been a part of those. But it stands for Extension for Community Health Outcomes. We are one of, oh boy, thousands of Echoes in lots of different arenas of healthcare and mental health care. I was on an Echo earlier about with doctors that work with adults with substance abuse issues. Our goals are to promote health equity, share knowledge, reduce disparities, and increase access and provide healthcare without barriers. Our goal really here is to bridge healthcare and education on this call. And we're a community of practice. So many of you have been with us every week, and we so appreciate that, you being with us. So that's what you'll see in almost any Echo. You can join an Echo in autism, or, I mean, really anything. And I was supposed to tell you this week what the goal of Echo is. Do you know, Dr. Prekker, how many people they want to reach by the end of 2022? I think it's over 1 billion. Oh boy, maybe Drake can find it. He's so good at following it up, far better than I am.
Maybe I can put that in the follow-up email. Yeah, we'll see.
Okay, by 2022, I believe Echo, because it's out of New Mexico, as we've talked about, and I think they're trying to reach 1 billion people with training by the end, and we would be a part of that. We would be a part of that billion. I hope I'm not wrong, and that it's much less than that, but I think it's a pretty impressive number. All right, next slide. So our 4 principles: technology to leverage scarce resources. Again, Zoom is something a lot of us are doing now, but this was really innovative, and it still is, in the days when we weren't using Zoom. I think it involved satellites and things like that, but it was really taking knowledge from university areas and areas where specialists were and reaching out and then hearing back from communities about what they needed. We use best practices, evidence-based practices. We always have a family story, or some medical field calls it a case study, to apply our learning. And we use data to monitor outcomes, such as Drake following up with you with a survey after this. We love having feedback. We love hearing what you liked about the sessions and additional things that you'd like to have. So this is session 4. We're super excited. Dr. Prekker is one of our favorite speakers. She does a wonderful job. Last week, Dr. Prekker, we did move the order around a little bit, but we had a wonderful session with a parent that had been in recovery and was talking about building recovery capital. And she was a parent who was actively using when her child was in the birth through 5 years. And she talked about that and gave us some really great insights into some things that early intervention providers could do to possibly support parents in that situation. So it was a really good session, and we are so happy to have you today for session 4. And we have a little more time. Dr. Prekker was with us our first time when we did it for 1.5 hours, which we were told was a little too much time. So we scrunched it into 1 hour for session 2, right, Dr. Prekker? And that was not enough time. So now we have 1 hour and 15 minutes. And I hope I'm ahead of schedule here. It's on 3:07. I'm actually over 2 minutes. So with not further ado, I'm going to thank you, Drake, for moving me along. I am going to introduce Dr. Prekker. he's moving me along. So today our topic will be with Dr. Francis Prekker, who is a pediatrician at Hennepin Healthcare. And Dr. Prekker, at times I haven't gotten this quite right, but you do a lot of specialty work in neonatal abstinence syndrome, correct? And NOWS, or you work with children who've been affected by that, correct? As well as their parents, but you are a pediatrician by training.
I am a pediatrician by training. And so
Okay.
my engagement with these families is in the hospital.
Great.
Sort of around the time of birth and after birth.
Okay, wonderful. Much like what happens to me sometimes when people say I'm a psychiatrist, I'm not. I wish.
Close.
I'm a psychologist. We last time we gave you a different specialty area than what it was.
I think I was a neonatologist last
Yes.
time.
And I think I did that. So anyway, I hope we got it right this time. But welcome, Dr. Prekker. We are so happy to have you today. And I'm going to just turn it over to you and let you get started and give your presentation, because I want to allow plenty of time.
Excellent. Thank you. Thank you so much for having me and allowing me to come again and talk about what is actually one of my very favorite topics. As Dr. Hall-Lande said, I'm a pediatrician. I work at Hennepin Healthcare. I am the medical director of the inpatient peds unit and also the newborn nursery, and have a really special interest in substance use disorders in pregnancy and substance exposed newborns, withdrawal in the newborn period, and then how to support the mother baby dyad, especially in the early childhood time. And over the last 12 years in clinical practice, I have developed quite a bit of clinical experience in this, although I don't know that anybody is an absolute expert. There are definitely things I don't know, but I've seen lots and lots of families affected by neonatal opioid withdrawal syndrome. Next slide. So we'll do a couple of things during this talk. We're going to define some of the terms that we'll be throwing around that are kind of confusing frequently confusing. We're going to talk about what symptoms we may see in a newborn who's experiencing neonatal opioid withdrawal syndrome, talk about the inpatient components of care, and then talk about some of the short-term and longer-term outcomes that we know about for children who are affected by opioid exposure in utero. Next slide. All right, so I always like to talk about limitations and the things that we don't know. There are lots of things that we think that we know, but there are significant gaps in the literature and things that we thought we knew maybe 20 years ago that maybe we didn't know as well as we thought. So there's a lot of change in the literature and a lot of things that we don't understand as well as we should. So I will do the best I can to explain my current understanding of this topic. However, I am positive that there are things that I'm going to tell you today that later we're going to discover are not as accurate as I think that they are, or there are terms that I'm going to use today that, in 5-10 years, we're going to decide that that's not the way that we would like to talk about that issue. All right, next slide. All right, so let's start with some of the basics. So you're definitely going to hear me in this talk discuss opioid exposed newborns. And so for this, we're talking about newborns who during pregnancy were exposed pretty much chronically or habitually to opioids in utero. It is not necessarily only illicit opioids. So it could be heroin or fentanyl, but it also is, it may be opioids that we've prescribed for a pain condition or things like methadone or Suboxone, buprenorphine for an opioid use disorder. Neonatal abstinence syndrome is the term that was originally used in the 1970s to describe the withdrawal symptoms that newborns would have after their mothers were using heroin while they were pregnant. It later sort of got generalized to describe any any newborn who is experiencing withdrawal-like symptoms in the early newborn period. And it could be to things like SSRIs or antidepressants. It could be to nicotine or benzodiazepines. So lots of different medications were sort of lumped in there. And then any baby who was experiencing withdrawal from those substances in the early newborn period was described as having neonatal abstinence syndrome. In the last 5 years or so, we've started using the term neonatal opioid withdrawal syndrome to try to sort of differentiate the things that are different about an infant who is opioid exposed versus an infant who is maybe exposed to antidepressants or nicotine in utero. Because the withdrawal syndrome that those kids have really is quite different, and that the treatment is going to be different than an infant who is exposed to an antidepressant or such. So in this talk, I'll use, when I talk about studies, I will usually use the term that they use in their paper. However, all of the kids that I'm talking about are going to be kids who are opioid exposed. So when I use the term neonatal abstinence syndrome, we're going to be using it just to talk about kids who are opioid exposed. The other caveat is that kids who are opioid exposed may also be co-exposed. So they may have been exposed to opioids in utero, but also alcohol or other illicit substances. Or not illicit substances, lots of things. You can be poly-exposed to lots of things. All right, next slide. All right, so I think that everybody's heard lots about the opioid epidemic and how it is affecting people in this country. And as the rates of opioid use in adults goes up, we also see the rates of opioid use among pregnant people go up. And as we sort of think about more pregnant people using opioids, we think about more infants being exposed to opioids in utero. So currently, let me just read off these because these are hard to keep in my head. So in 2019, the rates of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome in Minnesota was 10.3 per 1,000 live births. That was up from 1 per 1,000 live births in 2008. So we are seeing a significant increase in the number of infants that are affected by opioids in utero. And the differences are apparent by region as well. So you have the lowest rate of opioid exposed newborns in the southwest of the state and the highest at 34.9 per 1,000 live births in the northwest of the state. So it definitely varies by region. All right, next slide. As we think about pregnant people with opioid use in pregnancy, I think it's important to think about what this population of pregnant people is like in general, and the things that are demographically different about them than our general, than our population of pregnant people who are not using opioids during pregnancy. And so these are some of the things that are consistently shown to be different about the population of pregnant people who are on opioids or using opioids in pregnancy and those who are not. And I think that, you know, this is an important list to consider, and we'll talk a lot about this later on, is that some of these demographics are also associated with some differences in early childhood outcomes and pregnancy outcomes. So some of the risk factors we know for poor childhood outcomes are associated with opioid use in pregnancy as well. All right, next slide. All right, so how do we get an infant with neonatal opioid withdrawal syndrome? What is that from? So when a person is taking opioids in pregnancy, the opioids freely cross the placenta and easily get to the fetus. And after consistent or high dose exposure to the fetus, there are physiologic changes to the fetus that when the exposure to opioids stops at birth, the fetus experiences withdrawal. I think it's important to recognize that the infant is not born addicted to opioids, but they may experience physiologic withdrawal based on the in utero changes that they had now that they're no longer exposed to opioids after birth. Next slide. So at birth, it is actually impossible for us to look at a baby right after they're born and understand what that baby's withdrawal is going to look like. We would love to be able to predict this better to help guide families and prepare them for the experience that their baby is going to have. But it's impossible to tell just at birth exactly what that baby's withdrawal is going to look like. Here are some of the things that are associated with increasing severity of withdrawal from opioids, but none of these are sort of slam dunk. I can look at a baby and say, you're a normal birth weight, you're going to have terrible withdrawal. It just doesn't work like that. What we tend to see, though, is that infants who have been poly-exposed, so opioids and multiple other substances, are going to have a harder time. And certain medications or certain opioids are more highly associated with difficult withdrawal. I would say, in general, of the babies I see, kids who are exposed to methadone are likely going to have a harder withdrawal than an infant who is exposed to Suboxone. It's not down to every child you're going to be able to predict, but some of them tend to have some patterns. What is interestingly not associated very closely is the dose of opioid that the mother was on. And so women who can be on very high doses of methadone, and that does not necessarily indicate that their infant is going to have very severe withdrawal after birth. So we kind of have some ideas about who's going to have a harder time than others, but we can't predict at birth. Next slide. All right, so I think thinking about what does an infant who is starting to have withdrawal look like, and withdrawal symptoms are often going to start after the first day. Especially with the longer acting opioids, the opioids are still in the infant system, and you're going to see the withdrawal as those opioids start coming out of the system. So for things like a long acting medication like methadone, it might be 2 to 3 days before you start seeing significant withdrawal symptoms. The symptoms that babies are going to experience are usually broken down. I think it's easiest to break them down into these 3 categories. So your neurologic or neurobehavioral, your GI symptoms, and then your autonomic symptoms. All of this is a really fancy way of saying that these babies are usually quite cranky. They are irritable, difficult to soothe. They often have very high tone and lots of tremors, and they're difficult to feed, and they don't sleep well. So you can imagine, anyone who is a parent or has cared for a newborn can imagine that all of those characteristics make a really, really challenging newborn. All right, next slide.
Dr. Prekker, I love you, the cranky baby picture. You there's a perfect cranky baby. Just captures it. I just had to say something. Yeah.
So when we have an infant who's experiencing withdrawal, we try to use tools to assess that withdrawal and assess those symptoms over time. And this helps us understand and assess how severe the withdrawal is, and sometimes can help to us understand the response to treatment as well. So on the left here is called the Finnegan score. This was developed by Dr. Finnegan in the 1970s as she studied infants who were heroin exposed in utero. And it is very much a catalog kind of almost all of the symptoms you can have as a newborn when you are withdrawing from opioids. It's kind of long. Some of these things are a bit subjective, and they're also not necessarily specific to opioid withdrawal. You can have many of these things and not have been opioid exposed. So many normal babies you can get a score of, I don't know, 5, 6 on this just for doing normal baby things. So it's quite extensive, and it is not necessarily specific to opioid withdrawal. In the last 5 to 10 years, the Eat, Sleep, Console assessment tool and sort of care model has really kind of burst onto the scene and become very popular. And part of that is that it's much simpler. You can see that it'd be easier to do the Eat, Sleep, Console assessment every 3 hours as opposed to the other one. It's also been associated with improved short-term outcomes in infants. So when we care for babies using the Eat, Sleep, Console model, we're able to get them use less medication to control their symptoms and get them home out of the hospital sooner. So those are some of the things that really urge people or make people want to use the Eat, Sleep, Console model as opposed to the traditional Finnegan model. There are certainly limitations on both, and there is not one that is the only way to do it. There are lots of ways to do this. We at Hennepin switched to the Eat, Sleep, Console model about 4 years ago, and it has been, I think, a very, very positive change for us and for families. All right, next slide. So as we think about assessing kids for withdrawal, important to understand what our goals are. What do we want them to be able to do? What are we going for? Are we going for what looks like a stone cold normal baby, or what is our goal? So I think that this is a nice phrase that is from the AAP paper from about 10 years ago, talking about just we would like babies to sort of start to be able to do the normal newborn activities and social engagement. Next slide. So I think that, the way I think about this is really trying to provide infant and family-centered care is the best way we're going to achieve the goals that we listed on the last slide. Non-pharmacologic or non-medication care really should be the foundation of the treatment that we're providing for these infants. It's hard because in medicine, we like to do things and give medications and treat things. And this isn't very fancy medical care, but it is actually incredibly successful and really has made the outcomes for these children in the short term much, much better. So thinking about the caregiver, if infants experiencing withdrawal have a loving caregiver at the bedside and rooming in with them, their withdrawal tends to be less severe, they need less medication, and they have shorter lengths of stay. So engaging a caregiver to be the person at the bedside attending to the infant's needs is important. The environment matters. These kids are very easily overstimulated, and so do best in a very quiet, low disturbance sort of environment. So these kids were often having in a single room where the lights are dimmed, the TV's not on, there's maybe 1 or 2 visitors and they're talking in loud and quiet voices. We are respecting sort of a nice quiet experience for the baby. Supportive cares. I think, when we think about supportive cares for an infant experiencing withdrawal, they look very much like the supportive cares you would use for any cranky baby. Swaddling, having them have something to suck on, being held, being fed frequently if that is something that soothes them. And if they're sleeping, don't wake the sleeping baby. So the supportive cares is a lot of what you would do for an infant who is fussy. Nutrition is really important. We support breast feeding for a lot of these families. And if the family or the mother is able to breastfeed and there's no medical contraindication to it, we are very supportive of that. Breastfeeding is associated with less withdrawal or less severe withdrawal, less medication use, and shorter lengths of stay. These kids can often be very difficult to feed because they are disorganized and fussy and have abnormal tone. So feeding can be a challenge. They also have increased sort of caloric needs in the early newborn period of time. And so really making sure that these kids are getting the nutrition that they need, and it is likely going to be more than a non-opioid exposed baby. And then we get to medication. So I think people think about medication as sort of the most important part here, but I think it's way out there we'll get to that. And some babies never need medication to help manage their withdrawal. Next slide. All right.
Dr. Prekker, can I ask a quick question?
Yeah.
Is breastfeeding encouraged even if mom is still using substances? How is that managed or handled?
Right. So if mom is stable on things like methadone or buprenorphine and not otherwise using illicitly, then we support that. If mom has ongoing illicit use, usually we're saying not yet. And sometimes those are family mothers who have had a relapse around the time of delivery, and we say, all right, let's give you a period of time before, of sobriety before you start breastfeeding. And so we'll oftentimes help them establish a milk supply, start pumping, and then when they have had sort of a period of sobriety, we'll say now it would be a great time to use your breast milk. But that's a great question. And different institutions handle this in different ways. All right. As we talked about in the last slide, having an engaged caregiver at the bedside, oftentimes the mother is fundamentally important for these kids. And I think that we have to, as medical providers, figure out a way so that mom can provide that support to the infant and feel a part of the healthcare team. This is a group of women who traditionally have been judged and not treated very well in medical establishments. And so there's a lot of, we have a lot to overcome to gain the trust of women and engage them closer in the care of their infants and to support them doing the care for their babies. So moms are important. It's important to address mom's mental health, make sure that she's getting breaks from taking care of this cranky baby, that we are acknowledging the feelings of guilt that oftentimes are happening for her at the time of delivery, and just making sure that we're addressing her needs as well as the baby's. Next slide. The medication. All right, so medication is, I would say, an area of a lot of discussion, and there is not consensus on most of it. So you probably can't so there's no consensus on exactly which infants need medication, on what is the right medication to use, what is the dosing regimen, and how should we taper off medication. So lots of things that we in pediatrics will argue about. I think that the one thing that we can argue about, or we can agree on, is that if you are withdrawing from opioids and you need to use a medication, we should be using an opioid medication to treat that baby's withdrawal, not something else. That's about all we can agree on. All right. Medication is important for a select group of infants and can be very necessary. It is associated with longer lengths of stay. So if we're needing to use medication, the baby is probably going to be in the hospital for a longer period of time. Next slide. Right. I think that, while all of this sounds hard, and it very much is, I think it's important for us as providers and to, when we're talking with families, remind them that this initial period of infant withdrawal is really hard and can be just, it can be really, really challenging to go through that with an infant, but it's a self-limited process. The baby is not going to be in withdrawal forever, and at some point these symptoms are going to resolve. And remember the role of medication. It is not necessarily going to change anything about the long-term outcome for the infant. It's just going to make things look easier for the baby right now. And there are risks of using medication, which is why we don't use it for all babies who are experiencing withdrawal, trying to figure out what the sort of the balancing the risks and benefits. All right, next slide. Right, so by the time infants are going home from the hospital, opioid exposed infants are going home from the hospital, there are already outcomes that are different than their non-opioid exposed peers. And you can look at them there and note that here again, we have some differences in this population that also put them at increased risk for poor childhood outcomes. So already by discharge, we have some risk factors for poor neurodevelopmental outcomes. Next slide. All right, I'm a pediatric hospitalist. So my primary goal for so many, my view is always, how can I get this patient home? How can I get them to not have to be in the hospital anymore? And really for most babies and families who are have an infant who's experiencing withdrawal, discharge is only the beginning. So most of what happens with this infant is really all the time after. So I can pat myself on the back that I get them home, but there's a lot more that they are going to go through and a lot more that they need to think about after they leave the hospital. So I always think about discharge as kind of like the foothills. Next slide. So as we think about longer term outcomes, I think that this is the literature around this is even fuzzier than the literature around sort of what should we do in the hospital. And there are a number of things that I think are probably real in the sort of outcome, the longer term outcomes for children who are opioid exposed in utero. There's a lot of variability. Sorry, I'm not saying this very well. I think that the literature around longer term outcomes is very variable. There is some, these are the things that I've listed here are ones that I think that the literature is a little bit more clear on, and there's a little bit more consensus about the outcomes with these things. There are many other things that have been proposed as outcomes for infants who are opioid exposed, but there's less consensus about them. All right, next slide. All right, so one that I think that there's quite good consensus in the literature is that children who are opioid exposed in utero are at increased risk for having some visual problems in young childhood. So they're at quite in this one study, at quite increased risk for strabismus. So that's when your eyes are misaligned, nystagmus, which is the abnormal movements, and refractive error, so that you're not focusing correctly. So I think that this is something that, you know, as we're thinking about children in the medical system and early childhood, this is something that we need to be sort of thinking about and screening children who we know are opioid exposed to identify visual problems early, because we know untreated, these can have poor outcomes. Next slide. Motor development. I think that this one was harder to to appreciate, but there probably is some increased risk of abnormal motor development, at least through early childhood. So probably we should be keeping an eye on their motor development as well. Next slide. It appears that there is an increased mortality rate for infants who are opioid exposed. And this varies from different studies. In some of these studies, if you controlled for all of the infant and maternal characteristics, this difference in mortality went away. But in a lot of the studies, it stays, even after correcting for infant and maternal characteristics. What also seems consistent is that it is probably an increase in sleep-related deaths in that early infant period of time. So I think that this is another area in which that we as providers and as educators who are engaging with families in that early childhood and infants period of time should be addressing safe sleep and making sure that they have a good understanding of how to best prevent SIDS. Next slide. These children also seem to have an increased risk of readmission to the hospital. This varied a bit by study, but was one of those things that continued to come back up. In this study, you can see that the diagnoses for infants who came back into the hospital were a little bit different. Some of this makes sense based on the length of time that infants who are opioid exposed stay in the hospital. Some of these don't make a lot of sense for that. I do think that it is quite concerning that the children who are opioid exposed or had opioid withdrawal at birth were at increased risk for injury, unintentional injury, trauma, and poisonings. So a lot of injury prevention is probably a good thing for these children as well. Next slide. Cognitive outcomes. So I found this one the most challenging to try to wrap my head around. And because there are so many different ways that we can look at this and how many ways we can assess and over what time periods, you can see on the right there, I summarized a couple of different studies that show very different things. What I did find to be consistent, well, so I guess I will say, of the sort of studies I found more studies that suggested that there probably was a cognitive difference in cognitive outcomes for children who are opioid exposed versus those who are not, with poor outcomes, cognitive outcomes for those who are opioid exposed. The other thing that I did find that was fairly consistent is that children who were opioid exposed but had an enriched environment or had an improvement in their socioeconomic status did better. So some of the risks from the opioid exposure may be ameliorated by enriched environment and improving their socioeconomic status. So it's not as if we don't have anything to do. Next slide. Behavioral health. So I think that this is also one that it seems quite concerning to me and seems likely that there is a difference in rates of behavioral and psychiatric health problems in this population of children. It is, again, difficult to say if it is the opioid exposure or some of the comorbidities and co-exposures for these children that lead to the outcome. But it seems likely that these kids are at higher risk for some behavioral problems. Next slide. And then just other other things that these kids are at higher risk for. So just thinking about the other experiences that these kids may have in early childhood, as far as engagement with child protection system, the foster care system, experience of trauma and adverse childhood experiences. These kids are at higher risk than the general population for experiencing these things as well. Next slide. All right, so that is a lot, I think. You know, when I think about these children, I think about kids who are at high risk. And I think that at every step of the way, they are a population who is probably at higher risk for poor outcomes than their peers. But I think that one of the things that, as I look at these, at the literature and look at these children and families, is trying to figure out the ways that we can help to mitigate the risk. How do we help these kids reach their best potential? And I think that, you know, reading through the literature, I think that we do have a number of opportunities for helping these kids reach their best potential. And I think that that's why we're all engaged in this. I think that there is a huge role for early identification and early intervention services. So if we can get these kids engaged early and keep an eye on them and enrich their environment, try to minimize the disruption of potentially the ongoing substance use disorder in the family, keep them engaged in medical care. We are going to help these kids get to the best place that they're going to be able to get. And I find a lot of hope as I, you know, work with these families of trying to help them and support them through this process. So thank you so much. I know that's a lot of information over a short-ish period of time. What questions do people have?
Well, first, I want to say thank you, Dr. Prekker. You do such a nice job of distilling a lot of complicated information into a really engaging PowerPoint. I really appreciate it. I think sometimes it takes our group a little while to think of our questions, but I'm going to start with a few that I have, and then I think others can jump in, but usually I get the ball rolling a little bit. I have two questions. My first one is, typically do moms report, or are you aware that a child is going to be born with NOWS, or does it become apparent based on their symptom profile? I guess I'm just curious how that typically goes.
So I think it depends. It depends. Definitely there are babies that, you know, mom has been stable on her methadone for, you know, 4 years, and she was on it when she got pregnant. We all know that she's on it. We know she's, you know, hooked up with the clinic, and we know that we are ready for that. We've done education during pregnancy for her about what to expect. So we're all on the same page. We know it's coming. We are, for women who have illicit use during pregnancy or have, you know, relapsed substance use in pregnancy, it can be a little bit more of a surprise. Although we usually have some idea before the baby starts exhibiting withdrawal symptoms. So I can think of only one case in the last 5 years where I learned about mom's substance use because I was positive that that infant was having opioid withdrawal. And finally, after about 3 days, she finally disclosed her use. Testing during pregnancy and testing of the infant is it can be one of the ways that we just learn about mom's opioid use in pregnancy. But for most moms, we kind of have some idea that this is coming, so we can talk about it before the baby starts exhibiting signs of withdrawal, and talk about what we expect how we can make it better, how long we think that they're going to be in the hospital, how mom can support the baby. So most of the time we see it coming.
Great. Yeah, no, thank you. The other question that I have is, and it sounds like a lot of the moms with whom you work, you're aware they're on methadone, they're in some sort of a program, but does the hospital play a role in connecting them with any type of early intervention? I know in our state, it's not, for example, we've had some discussions in previous sessions. For example, in Ohio, a baby born with NOWS is auto-qualified for Part C birth to 3 early intervention services. And so they've made a policy change in their state around that. We don't have that in Minnesota, but they usually qualify through another pathway, related to their other needs, such low birth weight or things like that. But I guess I'm just wondering, is there sort of an active effort within the hospital to connect kids born with NOWS, or?
I would say not active enough.
Okay, yeah.
So that's number one. Right. As a part of our sort of guideline around how we manage these children in the hospital, as a part of their discharge plan, it actually, for all of these kids, it says, consider referring to Help Me Grow. And I would say there is a chunk of babies that get referred from the hospital to Help Me Grow. We do involve our occupational therapists with all the kids who receive morphine or opioids in the hospital to manage their, and so those kids will see occupational therapy again after they leave the hospital, sort of the medical system. But like last time you asked me this question, this is an opportunity for referring more of these children early. I think that oftentimes they're getting referred, sometime later in their infancy, when we start identifying that they're not having ideal development. They probably are getting referred then more often. So this is a good reminder to me. I'm gonna write it down again.
And my other question, which I believe I know the correct answer to, but it is no longer an auto referral. As we're talking about auto referrals, sometimes we have outdated ideas in our mind about, oh, well, it's an automatic referral to child protection. Laws have changed around that, correct? Or maybe they never were there. Help us understand, because I know, isn't the mom immediately, or isn't there, that is an old idea and incorrect.
It is complicated.
Yeah, okay.
The laws are complicated because there are different laws around reporting during pregnancy and what the mother's provider has to report, and the laws around what we as pediatricians and the caregiver of a child need to report. So there's level one of complexity. The law that changed recently was the one about prenatal substance use, and about so it used to be that the mother's caregiver during pregnancy needed to automatically report her if there was concern that she was using substances in pregnancy, except for alcohol. Interestingly, alcohol was an exception. That automatic referral to child protection went away. So now it is, if you know that a mother is using substances during pregnancy, you can engage her in care, and you don't necessarily have to report, although you can if she is not sort of following through with care plans or not showing up for care. The piece around newborns didn't change, which makes this really kind of tricky. So in Minnesota, if I think a mom used an illicit substance during pregnancy, I have to test the baby. And then if the baby is positive for anything, I have to report that to child protection. So it doesn't really match well but with the prenatal law and the what we have to do with babies. People are working on making it match better. So that it's a little bit less confusing. Well, so it makes a little bit more sense.
Yeah, that is hard. I didn't realize there was a discrepancy between the two.
It is
That
very
makes it hard on
confusing.
you. Yeah.
And
Yeah.
if we have a mom who's on, if we have a mom who's stable on Suboxone or methadone and she's been on it before pregnancy, there's no substance use concerns for more than a year ahead of her pregnancy, we have nothing that we're going to test that baby for. So it's not that every opioid exposed infant is going to get tested. It has to do with concern for ongoing substance use, illicit substance use during pregnancy. But the laws currently, I find them discrepancies.
Yeah. It sounds like it. Ben had some questions. Apparently I stole Ben's question. Sorry, Ben. Sorry about that. That's a problem, me asking the question. Ben had that question. And then he had the question, does it vary by states, what you were talking about?
Yes, all of it varies by state. So you can totally figure out how Minnesota works, and it's going to be completely different in any other state. So states vary a lot by this. So you need to figure out what the laws are in whatever state you are in.
And then Kim also had a question in chat. She asked, how much overlap is there with NOWS and fetal alcohol syndrome?
Oh, that's a good one. So I think most of the kids, I think, so the short answer is I don't see very much clinical overlap in the two children early in infancy. So if I see an infant who I think mom has been using alcohol consistently during pregnancy, I may not really see a whole lot of the sort of neurobehavioral dysregulation at birth. That baby may look 100% normal to me. Some of the physical characteristics of that baby at birth might be different. So they tend to be small. They have a higher risk of heart problems. And you may see some of the facial features that we sort of think about with alcohol exposure, although many of those are not really very easy to pick up at birth. Whereas an infant with NOWS, I would expect early in infancy, they're going to, they also may be small, but they're otherwise not going to have any physical features that are going to distinguish them, or I guess congenital physical features. But they are going to have increased tone, tremors. They're going to be very disorganized and fussy, and it comes in sort of a predictable pattern. So you're going to look pretty great on the first day, and by day 2 to 3 you're going to be getting more fussy, and you were feeding fine day 1 and now I can't get you to eat anything because you're so dysregulated. So later, so in childhood, you may not be able to differentiate them as clearly, and I don't have nearly as much experience with children with fetal alcohol exposure into childhood, sort of what they look like, but you may see some of the similar difficulty with regulation and behavior and sort of executive functioning. You may see similarities later on in sort of what those kids look like behaviorally, if that makes any sense. The kids who are opioid exposed without alcohol exposure, they are physically going to look normal. They're not going to see any of the sort of physical findings that we tend to think about with neonatal alcohol exposure. All right, that was kind of a long one. That's a good question.
Good question.
Complicated question.
Kim said, thank you. That was helpful. Are you seeing any more questions, Rick? I'm just trying to pop it up. I know you're
yeah, I don't see any others right now. And we might want to start transitioning to the family story in a minute too. Yeah.
Yes. Well, thank you so much, Dr. Prekker. We really, really appreciate not only the work you do, but you're spending some time with us and sharing your knowledge and wisdom. And I know you do a lot of work in this arena. That's how I met Dr. Prekker. I joined a group that is working, a group primarily of physicians, correct? And nurse practitioners that are working to improve care and support families in Minnesota. And I greatly admire that work. So thank you so much. And thank you for being with us today. We're going to stand on to our case study, which you're welcome to stay for. And you're also welcome. I know you're
I'm going to run. I got another admission that I got to go figure out. And thank you so much for, I recognize a little rambly today because my mind is in about 12 different spots, but thank you so much
it
for
was
the
wonderful.
invitation.
It did not come off that way at all.
Okay,
Okay to ramble, but you weren't. But you're getting some thank yous in the chat, Dr. Prekker. Thank you again, and hope to see you in the future. Take care, and we'll keep the rest of the group on with us. But thank you, Dr. Prekker. Thanks.
Yeah, thank you.
All right. So thank you, everyone. Dr. Prekker really has a wealth of knowledge and experience, and it's interesting to see. She deals with families for a pretty short but important time, right? Just in the hospital, while the family is there and the baby is there. And it's pretty clear to say her work's important, but the work we do in early intervention is more long-term and very impactful as well. So it's just interesting to see the different sort of segments, the different professions, the different disciplines that work with children with neonatal opioid exposure. So, all right, family story. So I am going to share this today. This was developed by Elise Holmes, which, just to credit her, was on our team for our first session. It was from Minnesota Department of Health and does work in this arena. Next slide, please, Drake. Okay, so our family story, the topic areas illustrated that were in the presentation: opioid exposed newborn, OEN. That's a term I don't use a lot, and I forget about that one. Neonatal opioid withdrawal, newborn child development, family system support. So the age of the child who is impacted in this family story is 1 month, and the setting of the case will be a home and a Part C referral. The child is a baby boy. And I don't know if you remember, but there was the slide that said boys are often, for some reason, boys, if they predict a more sort of significant neonatal opioid withdrawal, boys have it a little bit harder. I'm not sure why, but you see that in the literature. But a baby boy was born in a local hospital and was identified as an opioid exposed newborn. Mother is 19, and this is her first child. The father's also 19 and wants to be involved with the baby. Mom has a good support system of her parents and a large extended family who are there to support mother and baby. Mom admits she continues to struggle with opioid use and wants help. She also reports current symptoms of depression and anxiety, which is pretty typical. Mother's open to help with child from family and is interested in early intervention and early childhood special education. Newborn was born full term, but was small for gestational age, which we know is typical. He's struggling with eating, sleeping, and weight gain. Mother has been trying to breastfeed baby, but there have been feeding difficulties. We know that can be challenging for any baby, and especially babies who were exposed prenatally due to both motor and regulation issues. Sleep is also difficult, and the child and parent are not getting enough sleep. Next slide. What are the strengths, challenges, opportunities, and threats of your program? Okay. Mother and father both want to do their best and are open to support from systems and family, so that's a strength. Mom wants to actively work on her recovery. Large extended family that lives in the geographical area. Grandparents are willing to help with basic needs, providing, sharing their home, and mother and family are connected to a faith-based community. Some challenges: mom is new to her recovery. Her mental health, including anxiety and depression, needs to be addressed. Parents are relatively young. It's their first child, and they have little experience with babies and young children. There's eating and sleeping challenges with the baby that are affecting the parent and their mental health, and the baby is dysregulated and has significant sensory issues. Okay, this one's structured a little differently, and there's lots of information here. Okay, again, what are the concerns? I think this is similar to the slide we had before, right? Drake, mom, sooner recovery. She has ongoing mental health issues. Sleep is poor. I don't know if any of you remember that if you've had babies, but it's hard enough, let alone a baby. Babies with neonatal opioid exposure, their sleep architecture is extremely disrupted. It's very poor. Babies highly dysregulated, sensory issues, and high-pitched cry. We're very thorough with these symptoms, including 2 pages of it. All right, so here is your task in your small groups. What would you recommend to the family regarding prioritizing interventions to seek out and to deal with transportation needs, as well as other challenges? How can family-centered early intervention process support this mother and family who love their child and want to do everything they can to support him? What other strategies and supports could be tried? So those are your 3. I think the number 1 is, what would you recommend to the family regarding interventions to seek out? And also, this may have been cut from the case study. The family lives pretty far out from any type of services and supports, and transportation is a challenge. I think that might have gotten cut out. So that's not as random as it seems. That was one of their challenges. They live kind of in a more isolated area and don't have good transportation, which could also be a challenge to recovery programming. All right, Drake's going to send people into small groups. We'll be there pretty quickly, and then we'll bring you back and let you go for the evening.